Good afternoon, ladies and gentlemen. I'm called by name Zilemko Esther. I'm from Nakapulpit district. I am a teenage, I'm a child, let me say child mother. Due to the negative thoughts I got when I was in school. My primary was okay because my grandma was there. She was supporting me until I reached P7. When I reached senior 1, things became hard. My grandma could not afford school fees. I went to my mother, and my mother is a woman who sells tobacco to make a living. I grew up not knowing my father because my father was killed when we were young. I had a brother and 2 sisters, and I'm the firstborn of my mother. So my mother could sell tobacco. I tried to explain to her that I had interest in being in school, but it was hard for her to raise the school fees they needed in school. I had an auntie who could help me in paying my school fees. But because even her had her own responsibilities, she had kids, her sisters, her relatives, it became hard for her also to support me. But I could do brewing with my mother while selling tobacco, helping my mother. I finished senior 1. When I reached senior 2, things became hard. I couldn't go to school anymore. I came back home. I worked as a maid just here in Kampala. I worked for 2 terms looking for school fees. But all it was in vain because the woman who was supposed to pay me because I was her maid could not allow me to go to school. Her kids became used to me to the point she could not allow me to leave to take care of her kids. I went back to Karamoja because I was heartbroken. I've worked in vain and I wanted to go to school. I really wanted to be in school, but it was hard. I went back. I stayed just there helping my mother to sell tobacco. She could sell a cover of that Renzori bottle, 200. So I waited for my mother. It was really hard for her. I ended up having a boyfriend, and he promised to take me to school because the auntie had a restaurant and he was the one managing the auntie's restaurant. I thought I made a right choice. But in that, I did not make it back to school. I got pregnant. I have a son of 3 years. I've been the mother of that boy and the sister, the father, everything. I came back from Moroto 3 days ago. I'd taken my child to get surgery. So, my life is hard, but I managed because I started up a business of cooking porridge. That is when I gave birth to my child. I started making porridge in the street, moving with it, just to earn a living, so that I can provide for my child and myself. I cooked porridge. I've been cooking porridge for all that. Until now, I'm still cooking porridge from the street. That is what I earn for a living and taking care of my child. But as me, I really have a feeling of going back to school. I wish anyone could even support me right now. I would go back because I have seen what life is. Without education, you're nothing. There's no brighter future for you in front. You're just like a piece of wood they put inside the charcoal stove. The only thing I can advise others who are still in school, please, you have an opportunity to study, focus. Do not allow anything to distract you from your goal. Achieve your goal the way you want. You might be having dreams of to become whom you want in future, but don't allow anything to stop you. Because when you stop, you will always have regrets, like I do now. Please, my fellow youth, my fellow sisters and brothers at school, focus on your studies and achieve what you want. That is my advice to those ones who are still in school. And those ones who are like me now, child mothers, do not give up. There is always an opportunity that you will get in time to come. Education has no age. You can still go back to school. That is what I can tell you, mothers like me. Thank you.
Very, very, very good. Thank you so much. I thought we could give her a better round of applause, really. You see, many of us have stories to tell. It's not very easy for you to get a mic and speak about your experience in a forum like this. So I'd like to appreciate her for allowing to share experience with us, because it means she's playing her role to create the difference that we want. Many of us have our stories, but we keep them to ourselves. Yet those stories would actually contribute to creating a change that we want. So I would like to thank you so much for sharing your story. And I like where you say, don't give up. That's a key message. Things can turn. We have all been in different situations today. Tomorrow you'll be totally in a different setting, and people will not even remember where you came from, that it was as difficult as it was. So never give up. Continue struggling to achieve the best you can. That's what life is. If you want something, you struggle to get it. You struggle personally, individually to get it. If there are people who can support you through that journey, well and good. If they are not there, you don't give up. You continue pushing until you reach the success that you want. At this juncture, I want to invite Laura to come and take us through our panel discussion. Let's give her a round of applause as she comes.
Well, it's good morning, no, good afternoon, and ready. Good afternoon again to all of you. You got your second snack, so the energy should be a bit up for now. So let me repeat again. Good afternoon. I need your energy, and I'm sure that you will be energized by listening to our panelists as we move forward. My name is Laura. Truly my name is Laura Criado, but I'm always introduced with my second surname, that is Laura Lafuente. I am the program coordinator for gender and youth at UNFPA. And as my friend Frank has shared, I have been here 4 months now in Uganda. I'm coming from Malawi, and I'm very happy to join the wonderful extended team that we have here today as we take a stock about what we have done to end child marriage and what else we need to do. So the focus of the panel discussion as the theme of the National Symposium 2023 is focused on translating laws and policies into appropriate support services for pregnant girls, child mothers, and their babies. The panelists are a representation of different stakeholders that are called by the National Strategy on Ending Child Marriage and Teenage Pregnancy to play and key and pivotal role on implementing the strategy. And on implementing the strategy, we have, of course, the lead ministry, that is Ministry of Gender, Social Development of Labor, and we have the representative, that is Mr. Rogers Goloba, Senior Provision and Social Welfare Officer from Ministry of Gender. Please, a big round of applause for him. As he comes to the stage, we will have also representation from Ministry of Health. My friend Dr. Mutumba Roberts, Acting Assistant Commissioner for Reproductive and Infant Health Division. A big round of applause for him as well. We have from Ministry of Education, Ms. Rosette Nanyanzi, Gender Technical Advisor from Ministry of Education. I'm sure that most of us, we know Ms. Rosette, as she helped us from gender perspective to implement all those programs. And finally, allow me to call Ms. Lucy, our key partner as well from Ministry of Justice, supporting access to justice for girls and young women for all gender-based violence cases. So a big round of applause for Ms. Lucy as well. I hope we have, yes, please take your seat. Thank you so much, dearest panelists, to be here with us as we talk about access to services for girls and young women, especially pregnant girls, child mothers, and their babies. Why we have coordinated with Ministry of Gender to have this specific topic and theme as a priority for the National Symposium. I think you heard this morning Lydia from Ministry of Gender, also myself as well, talking about the statistics in terms of the burden of teenage pregnancy in Uganda. We talk about 1 in 4 girls are pregnant or have babies before the age of 19. And we need to ensure that we give a second chance to the teen mothers in this regard. And for that, they need access to services. If we don't act now and provide access to services to the teen mothers, we will not achieve the demographic dividend. If we don't invest on young people, and especially girls now, we will not achieve Vision 2040 as the government of Uganda. So we really need to ensure that we take a stock about how are we supporting girls and young women to access the services that they need, to realize their rights, and ensure that they can continue to contribute to the development of the country. So this is the main topic of the panel today, and we will hear from the different perspectives, from the different ministries and MDAs, to ensure that we learn what are we doing, but we also learn what are still the gaps and what else we can do. So we would hope to hear your commitments from each one of the ministries that you are representing, what else we can do and what we will do different moving forward. So with this background, allow me to start the panel. In terms of time for the audience, I hope that we can run the panel at least for 45 minutes. So I'm asking my panelists to keep time, and ensure that we keep the responses to 5 to 7 minutes each maximum, and I will be supporting you with that time management as well. And we will have 2 rounds of questions. So allow me to start with Ministry of Education, with Ms. Rosette. As we learned this morning, one of the key achievements recently has been the development and approval of the re-entry to school guidelines for pregnant girls and teenagers. So the overall purpose of the guidelines is to support the management of teenage pregnancies in the school premises. So we would like to learn from you for what extent the guidelines are being implemented in Uganda, and what are maybe some of the learnings and recommendations from the implementation that you can share with the audience. Thank you. Over to you, Ms. Rosette.
Yeah, thank you very much for that overview of this panel. My colleagues, my name is Rosette Nanyanzi, and I'm to share about these guidelines. Maybe a brief about these guidelines. These guidelines, before 2020, Ministry of Education in 2015 had developed guidelines on prevention and management of HIV and teenage pregnancy in school settings. So during that time of the COVID-19, we had a review of these guidelines, and actually the aspect of re-entry of the child mothers was not taken into consideration in those guidelines of 2015. So we embarked on the review of these guidelines, specifically to speak about the re-entry of child mothers, because it's one way to prevent, but if it happens, what do we do? So we developed those guidelines, and we've been able to disseminate these widely. So far, we have been to over 188 districts, and we have covered a number of stakeholders, and these include the political leadership, the technical wings of the districts, as well as to our teachers and learners. And when we talk about the teachers, if we are talking about re-entry, this is where the children have to get back, and we need to prepare those children to get back. But of course, these guidelines could not go alone. We've been able to develop messages around these guidelines, but also ensuring that these young people can be able to return to school, and also ensure that they get the right kind of information. What happens when you are going through this stage, and then how do you manage? Of course, we've been able to strengthen the school clubs to ensure that we have an opportunity and a space where young people can actually speak about these issues. In 2022, together with the UNICEF, we embarked on the development of a life skills toolkit. This is intended to provide information to young people. We have seen over time that if young people are not part of the discussions, not part of the issues that concern them, maybe we may not be able to get the results that we want. So that toolkit is being rolled out. So far we have reached about 1,000 schools, but that is just a drop in the ocean. We need to do more as far as that is concerned. We have been running multimedia campaigns with different stakeholders, World Vision, Plan, to ensure that we can be able to reach out to those regions that are struggling with these issues. And as a result of those multimedia campaigns, in Karamoja alone, we have at least seen 3,000 learners re-enrolling, and for us that is a plus. But we have also been able to see over 827 cases referred to other skilling opportunities. Much as we are providing a second chance, some children may not be able to return to the formal system. So what else do we do? And that is what we've been able to do to make sure that they can be linked to vocational services and they continue. Some time back, the Ministry of Education had developed the reporting, tracking, and response guidelines. We know that when all this happens, is it reported? And when we report, do we follow up? Do we take actions? So for us to ensure that these guidelines can be utilized by the different stakeholders, we've been able to translate them into local languages, and we have a version for police. Even at the police station, they should know when this child gets here, what do we do? We have been able to develop one for the health workers, but also for the community and the learners themselves. So dissemination of these guidelines is still ongoing, and to ensure that they work, we have been able to add a case management register at that level so that cases can be reported, recorded, and followed up in a systematic manner. The Ministry of Education, sometime back in 2018, developed the sexuality education framework. We have had challenges with its implementation, but what we have done now is to integrate this into our lower secondary curriculum under subjects of biology, religious education, general science, among others. And we hope that through the curriculum, young people can be able to get a lot of information that they require concerning their growth and sexual maturation. The intention is to ensure that we prevent. So that is what we have been able to do as Ministry of Education. Thank you very much, Rola.
Thank you so much, Rosette. I think a big round of applause for Ms. Rosette. I appreciate the brief summary information, but very key and informative response to the question. Let me repeat, I think the final words as we have takeaways is prevent, and prevent. This is the focus of Ministry of Education through the different interventions that Ms. Rosette talked about. And let me highlight as another takeaway that for the rapporteur as well, as we heard this morning from Ministry of Gender, the representative from the PS, Ms. Annette, in the highlight, the call for all of us in terms of coordination as its stakeholders. I think Ms. Rosette talked about the reporting tracking and the case management system to track the girls that are dropping from a school. And this is key data for us, for the other ministries here represented, to ensure that they get the information from the from the provision officers, from the health service officers, to ensure that they support with access to services to the most vulnerable ones, that are the ones that are dropping from a school. So those other stakeholders, they need this data. So I really celebrate this reporting, tracking, and case management system as one of the key tools that can enhance coordination among the representatives in the panel. So thank you so much, Ms. Annette, for the response. So let me move to Ministry of Health, Dr. Mutumba Robert, in terms of maternal health and access to sexual reproductive health services for adolescent health. We have seen that one of the key, and this is part of Uganda Health Demographic Survey 2022, one of the key areas that is contributing to the high fertility rate, that is, as 2022 standing at 5.2, is access to contraceptives to delay the second pregnancy. And this is one of the key areas for teen mothers in terms to delay the second pregnancy after they delivered the first child. So access to services, access to information is key. So can I ask what the Ministry of Health, what are the interventions that Ministry of Health is leading, especially at the district level, to ensure that adolescent girls, they have access to ASAR information, especially for teen mothers? Thank you.
Yeah, so thank you so much. And number one, at the Ministry of Health, we believe that the teenage pregnancy problem is a problem that cannot be solved by the Ministry of Health alone. So we are embracing an approach where we work closely with our other colleagues in the other sister ministries, like the Ministry of Gender and the Ministry of Education, but also working with the state and the non-state actors. And so for us, that's what we believe, that if we do not work together, we will not be able to achieve in terms of seeing a further reduction in the teenage or adolescent pregnancy problem. So what we are doing, especially now that we are talking about the district level, is the issue of ensuring that we have a proactive leadership that is interested in the issues of adolescent health. and in a number of districts. I think we have not yet reached half of the districts, but what we are trying to do is to ensure that we have active district committees on adolescent health, the so-called DICAs. And every year, again, the Adolescent and School Health Division at the MOH keeps track of how many more districts have functional DICAs. So once you do not have leadership at that level, we can only continue to discuss such issues, because it is eventually the leadership that is going to incorporate a number of those interventions within our running program budgets for us to have successful interventions. So that's one. It's really around the leadership. But also number two is the issue of the use of data. So you realize that, yes, at the national level broadly, we are able to have a clear view of which districts, even as we do the focusing, we are informed by the data. And I think this, if I had an opportunity to flash a map of Uganda here, shaded with different colors, you will be able to appreciate the districts that have the worst indicators in relation to the teenage pregnancy, but also maternal and newborn health outcomes, largely for all women, but most importantly, for the adolescent mothers. And like you've rightly put it, yes, we see the reduction in our country's maternal mortality ratio from 336 per 100,000 in 2016 to 189 per 100,000 as of the UDHS 2022 result. But one critical factor that remains significant is that over the 5 years, the maternal mortality, the mortality is increasing among the teenage mothers, and that keeps the mortality ratio high for the country, and that makes teen mothers and adolescent health a priority intervention. And at MOH, as we speak, it's really one of the top priorities. I think even when you hear the senior leadership discussing issues of maternal mortality, we are diving deeper into the adolescent health and, the mortality issues. Because if we don't, then we will not have a further reduction from the 189 to the SDG target of 70 per 100,000 by 2030. But also the other things that we are critically undertaking at the district level is the aspect of ensuring that our health workers who actually attend to these young people broadly have been oriented on what it means to provide a service that responds to the needs of this young person. We have previously had scenarios of insults where, for example, young pregnant mothers show up at these facilities, and they are, in some isolated scenarios, receiving care that is really suboptimal. So what we are actually undertaking is now what we call a whole site orientation. Previously, we used to orient, let's say, midwives, the doctors, but we have also noted that it's important to also reorient even the askari, the gatekeeper. As this adolescent teenage mom enters the facility, the reception that this young girl will receive from a askari also matters. So we are undertaking whole site orientation so that all our health facilities, the entire health workforce, is really responsive to the needs. The other critical aspect that we are vigorously undertaking is really increasing access to SRH information and services. We did a regulatory impact assessment some time back and realized that many of these young people are really quite naive. And I think some of you have heard statements, young people saying that if you have sex while standing, you cannot become pregnant. That level of naivety is actually getting these girls pregnant. And so increasing access to information is part and parcel of our major frontline in terms of intervention. We want to appreciate, as the Minister of Health, different partners that have come in to support the reproduction of a wide range of IEC, information, education, and communication materials on adolescent health. We are not yet there, but if you look at the coverage map, if every year we keep increasing, the number of districts and facilities that are able to provide services that respond to the needs of the young people. At the national level, we had developed a draft adolescent health policy, but we recently got feedback from the cabinet secretariat that government is now running away from policy fragmentation. So what we are now doing is we have successfully incorporated the key aspects that we had in the adolescent health policy within the National Health Policy 3 that is yet to be incorporated. But we have also started on a process of developing a national adolescent health strategy so that the districts have a clear framework that is guiding implementation of adolescent health services. And probably lastly, as I wind up, the discussions around increasing access to contraception, especially among the teenage mothers, is a sticky one from different stakeholders. People never want to hear anyone talk about access to contraception among a teenage mother. But in our death review meetings, we discuss especially the teenage mortalities every Monday and Thursday. We have mothers at the age of 22 years who die, but after, so I think last week we had a case of a 22-year-old mother who died, but she was pushing her 5th child at 22 years. So that means that probably the first child was at, you can quickly guess through, probably 13. And then when you have a discussion around this teenage mother who has already produced 2 children by the age of 15, and you're discussing how do we support this mother to space children, because at that point, she's most probably in some sort of a relationship, and then you have different voices coming in. And so sometimes those are realities that we face. But ideally, what we are really trying to do is that for these teenage mothers who have actually produced once or twice or thrice a conversation of how they are going to access contraception is one of the things that we are gradually, and I think the biggest challenge here is that when we talk about adolescents, people quickly think through the 10 to 19. Yes, that's the definition, but they fail to appreciate the different categories of these adolescent girls. They are adolescents who are in school, adolescents out of school, adolescents who are really in different, they are adolescents who have been customarily married off, 15, 16, you had scenarios here. So I think as a country, if we can get to a level of disaggregating the different young people categories and designing and being able to provide interventions that are tailored to the different categories. And I'm very sure nobody would really talk about issues of contraception in an adolescent who is in school busy reading books. But the adolescent who has been already married off in union, producing children, I think that's something that should be healthy, and those are some of the things that we are really trying to address. And yes, very lastly is we are also undertaking, we call them VCAT sessions, value clarification and attitude change among health workers. This has been a very big issue, that some of these young people show up at some of our health facilities. I keep saying some, because then largely you'll realize it's not a big issue across the entire country. So we think that once we undertake these VCAT sessions with a number of health providers, they'll definitely be able to understand the unique needs. These young people come in different forums, in different categories, and we should be able to prescribe different interventions depending on the different categories of these young people. Thank you.
Thank you so much. Thank you so much, Dr. Mutumba, sorry. Yeah, still with my 4 months, the pronunciation is not yet there, so I apologize for that. Thank you so much for the response. I think, Doctor, you gave us a key direction moving forward in terms of tailored interventions to ensure that we focus and prioritize the most vulnerable girls and teenage pregnancies. You said very clear and loud, not all adolescent girls have the same needs. So we cannot approach them with the same packages. So we are really looking forward to see those tailored packages as part of the adolescent health strategy that is being developed, and the clear guidelines for the district health officers to implement those tailored packages. But I think it's also important to highlight from all the interventions that you shared with us, the importance of life skills. At the end, it's about the girl making their own choices about their body. We are not making choices about them. And the government of Uganda, as we shared this morning, has ratified the ICPD plan of action. And in that plan of action, there is a specific clause of the rights of all individuals and couples to make their own choices about when and with who have children and the timing of those children. So this is a right for all couples that the government of Uganda has ratified in this regard. So we hope to see that contextualized in the adolescent health strategy. Thank you so much again, Dr. Mutumba, for that. So let me move to Mr. Rogers Goloba from Ministry of Gender. I think the ministry has learned a lot from COVID-19 in terms of childcare and protection services. Regarding the increment in terms of teenage pregnancies and child marriages that took place during COVID-19, what are some of the key prevention and response services that are now available for adolescents at risk of child marriage and teenage pregnancy from a child abuse and protection perspective? Thank you.
Yes, thank you, Laura. First of all, mention that the COVID-19 pandemic was a learning period for us. First of all, if you look at all the emergency response plans that were in place, that were being funded, I think most of the critical areas that were missed were issues related to the effects of the emergency on children. Most of them were mainly health-centered, maybe learning, but we all know that the children, I think, faced the full effects of the pandemic in terms of their social and health well-being. So fast forward to the Ebola emergency, I think we saw more concerted effort by partners to see that issues that affect children were actually mainstreamed in that response. That is including all our child protection systems as part of the response. And we believe that we were able to pick a lot of good outcomes because this time round, I think there was a review and they saw it fit. Now, as Ministry of Gender, we recognize that actually majority of our children are out of school. If you compare the population of in-school children compared to the actual population statistics for that particular age group, you recognize that most of the children are out of school. But to make it simple, if you look at the completion rates, for example, for primary, I think it's 40%, means that at least 60% are out. For secondary, even for tertiary institutions, which post-primary, look at our universities. In total, we have at least 40,000 youth graduating from all tertiary institutions. So it means that we have to intensify our efforts in targeting these children, first of all, to live healthier lives, to be safe, but most importantly, to be able to participate in all decisions that affect them. As Ministry of Gender, there are a number of services that we provided as part of the prevention of child marriage and teenage pregnancies to the children mostly out of school. Obviously, we didn't work alone. We worked with all key stakeholders here. And for this platform, I think we're all under the Human Capital Development Program, health, education, gender, and then water and environment. First is we provided child protection services to those children. Remember, we had a big discussion about keeping our helpline online, and we're able to get that, I think, in the shortest time possible. We're able to ensure that our social protection workforce was part of the essential service workers during that period, because we believed that in the beginning that was left out. When they came on board, we began picking the cases and responding to those emergencies. But we also provided individual and group rehabilitation services for the children who are at risk. Through our approved children's homes, we're able to rescue children who are at risk of child marriages and place them there, while we engaged with the parents and communities to be able to reform their decisions. We focused a lot on our interventions at improving parenting practices in the homes. I think most of you have interacted with our programs. What we also recognize is that we also have very obvious, when we talk about child marriage and teenage pregnancies, they bring on board a huge population of very young parents who lack the knowledge and skills, first of all, to take care of themselves, but also to take care of their own babies. Then secondly, they are not in the right mental state of mind. That is already compromised by the situation that they are going through. The social stigma, the limited support from their parents, the desertion by their boyfriends or their partners, who may be mostly of the same age. So through our parenting programs, we're able to target parents, but also target those children who already had babies to take care of. Our programming under orphans and vulnerable children was also available, because we also have a special category of children who are not like the rest. I'll talk about the children living with HIV, children who are on the streets, children in child-headed households. We're able to provide them particular support during the COVID-19 pandemic, and most of the services that provided them, including providing food rations for them, linking them to support for health care through our VHTs, was highly, highly important. One of the key things that we did during that particular period is pilot 2 key interventions. Together with UN Women, with Ministry of Education and Sports and FIDA, we piloted a model called Addressing Barriers to Empowerment and Education of the Girl Child. And we had interventions at individual level, at family level, and at community level. And we worked together with the Kingdom of Toro to provide that intervention. And through that model alone, we're able to ensure that over 1,000 children from the districts of Chitagwenda, of Kamwenge, of Fort Portal, of Kabarole, were able to return to school. And what surprised us was that we just opened up people's minds about what they can do, strengthening governance and accountability for issues to do with child marriage and teenage pregnancies. If you're a head teacher, can you notice, for example, that a group of girls is occasionally missing school? Can you really follow up with their parents to know what is the problem? Can you talk to their parents to see how they can support the scholastic materials without necessarily giving them financial support or material support? And we're able to achieve a lot of success in that. For those of the girls who are not able to return to school, who had given birth, we're able, again, working with the district to link them to vocational schools and get sponsors for them to continue with that level of education. So for us, in terms of response to that particular pandemic, we were able to do a lot of things. The other pilot that we are currently working on, which started during the COVID-19 pandemic, is the pilot for the community differentiated service delivery model. Because when we talk about child marriages and teenage pregnancies, one of the things that is a big elephant in the room is HIV/AIDS amongst our teenagers. And HIV/AIDS actually amongst our teenage girls. So it's a very, very triple burden. And what we saw is that even for the adolescents who were supposed to be adhering to the ARVs, most of them had several challenges. Remember, adolescents are actually relating with the same girls that we are talking about, to their age mates. So we saw that this is actually a time bomb, and we're able to pilot how we can have the peer-to-peer approach, how we can bring parents or caregivers who are staying with these adolescents who are living HIV on board to support them to adhere, but also to communicate with them, provide the nutritional support that is highly important for them, but also to ensure that they live positively without necessarily engaging with our other girls. So with those two models, we're able to pick a lot of learnings. The community differentiated service delivery model is currently being scaled up, and we do hope that it's one of the things that can enable us tackle some of the biggest challenges in the room, especially affecting our teenage girls who have babies, but also for those who are having new relationships, first-time relationships, or having their first sexual debut, so that they can have the urgency to be able to make correct decisions, healthier decisions about their lives. I'd like to thank you.
Thank you so much, Mr. Rogers, for that overview of all the learnings, interventions that the ministry led during COVID-19. We are, I think, really looking forward to see how the ministry would be able to take some of those success interventions moving forward from a sustainability perspective and ensure that this can be a scale up to other districts that are facing similar challenges. So we will be looking forward to that response. So before we are moving with a quick second round, I would like to open the panel for questions from the audience. As an audience, we have mainly representatives from the districts. And what the ministries are leading at the national level should be mirrored at the district level. So it would be great to see if at the district level you see those interventions taking place, or maybe what are the gaps that you are seeing at the districts that you represent. So maybe we can allow, because of time, 2 to 5 questions maximum. I suggest that we take all at once. Kindly be brief, asking your question, 1 minute per question, and please, panelists, you can take note of the questions. I see one question from Karamoja, from Charles there. A second hand in this table. Third, fourth, and fifth. Yeah, I have 5 questions already. So, Charles, over to you. Please introduce yourself and keep the question to 1 minute maximum.
Thank you very much. My name is Charles Clark Loda. I work for UNFPA as Program Coordinator, stroke Head of Sub-Office for Karamoja. My question to the panel is, we've heard about the policies, the interventions that are working and what's not working, but I just wanted to hear from you, how do we strengthen accountability for teenage pregnancy at the field level? And I'll speak that with a very specific example. Last week, I was in the field to visit a school called Kwakangol, something like that, Kakingol in Moroto. And while I was going to the field, a colleague of mine had hinted to me of a young girl. She's around 13 years. She's the only child among the staff years who is pressing on with school. She's 13 years and she's in P6. When I reached there, I looked out for that girl. We were doing an integrated sexual reproductive health services outreach and community engagement. I spoke to this girl and I saw her plight. She's constantly living in fear of being the next first bride. She's staying with a teacher. She's an orphaned girl. She's the only one in primary 6, staying with a teacher who has volunteered to help her accommodate her. Never mind the protection issues that come with that, but she's at risk of falling out of school. So the system is failing her. And when the system fails her, our colleague, the representative from the Ministry of Health, the Ministry of Health is always the recipient of failures across all other sectors.
Can you keep the question short,
I've already highlighted the question and given it magnitude. So what I wanted is it possible, because the Ministry of Health, for every death, there is a triggered response. Every maternal death, there's a triggered response holding people accountable. Where have we failed this mother? Why aren't we doing that when it comes to teenage pregnancies? That's my question. I hope I've been able to.
Thank you so much. Yes, I guess this is for Ministry of Health especially. Second question.
My name is Ben Sakaja, the District Community Development Officer Bukwa. My question goes to the probation, the probation officer for the ministry. For us at the district, it has become increasingly difficult for cases of children to be handled in police, in courts of law, and I wanted to know if the Minister of Gender is in touch with the Minister of Justice, because as we speak, so many cases have never been, there are so many cases which have never been concluded, and they are just there, and the children are suffering. So I wanted to know from probation ministry as to what they are doing.
Thank you so much. And as we have Ms. Lucy as well from Justice, and we will ask the question, maybe she can also comment on the question. I think we have two hands over. Well, yes, sir, go ahead, and then we'll move to the two girls.
Yeah, thank you to the panelists. I have one question for Minister of Health. There is a very serious issue of medical examination charges for survivors of GBV across the health facilities, right from Health Center 3 up to the main hospital. What is the ministry doing to stem out this practice? And then two, I would like to ask my brother, Mr. Rogers, why is it that the politicians are failing to appreciate the work of the social workers? During COVID-19, the president did mention that there are certain issues that are not urgent. Issues where people pinch themselves at household level, was referring to GBV, that one can wait. Then of recent again, we had the president coming out in the open to condemn women's studies. That why should people take up to 3 years to study about women in universities? So this one tells me that there is a gap. Ministry of Gender has up to 5 ministers that sit at cabinet level. Is there a way we can cause mindset change at cabinet level? Thank you.
Thank you so much. I missed your name and your role, sorry?
I am Ojok Jimayen, DCDO Kabong.
Thank you so much, and please, we move to the last two here.
Thank you so much. My name is Zapili Nelly from Gallup Initiative, Uganda. My question goes to Ms. Rosette. You have said about your entry of child mothers in 188 districts, but I ask on behalf of mothers with disability. How far have you gone on helping them, or are there any other special programs for them apart from re-entry into schools? And another goes to health. We see in different health facilities welcoming different able people, but so far, whenever I go to them, we don't see programs welcoming people with disabilities, especially teenage mothers. Are there some special trainings that your health facilitators or health workers have? Thank you.
Thank you so much for the question.
Good afternoon, everyone. My name is Naguja Hanifa from Gallup Initiative, Uganda. I'm having 2 questions for Ministry of Health. First, I want to ask how has the ministry worked towards strengthening families, because we know families are the main cause of these early child marriages and pregnancies. And another question, we all know that it is not bad to give birth. Actually, it is one way that our population increases. So I want to ask in a health perspective from the minister, from that representative from the Ministry of Health, that what is the recommended age, so that when we go back to the girls that we are presenting, to tell them that information from the people themselves, the right information. Thank you very much.
Thank you very much to the audience for the questions. You will have more time to interact with the panelists, I think, during the lunchtime. Let me just recap some of the questions, and I think because of time, we will also catch up with the remaining rounds for the Ministry of Justice, for Ms. Lucy, as well as we respond all at once. So we have a number of questions for Ministry of Health regarding, first question on strengthen accountability of teenage pregnancy at the district level. Ministry of Health responds on SGBV cases, as well as the technical questions asked for from the girls in terms of access to services for girls with disabilities at the district level. So we can start maybe with those questions for Ministry of Health. Thank you.
So thank you so much for the questions. And I want to begin with the first question around the accountability for teenage pregnancy and the scenario that was brought through of that 13-year-old girl. You will actually realize that the answer to this question requires everyone's attention. And I think that's what I started with, that the Ministry of Health alone cannot actually address the teenage pregnancy problem. So again, keeping in mind the scenario highlighted, the social structures have to come in and support that 13-year-old girl. And that goes beyond the Ministry of Health in terms of where that girl has to live, who has to speak to that girl, and all that. And I think for me, I'll leave it at that everyone has a role in supporting that 13-year-old girl so that we do not count her as part of the next teenage mom. And the overall accountability for all the girls that become pregnant should be a responsibility for everyone. Number two, the extortion. I call it extortion, the way it's been raised. The medical personnel that ask for money for examining survivors of GBV. This is an issue because we've had interaction with some of these medical officers, and they will tell you that once the experience is that once they come in and provide the medical services, they tell us they are very okay with providing the medical services in terms of if it's PrEP, if it's PEP, if it's, providing treatment. But when it gets to filling the police forms, the medics are telling us that there is a time where they get called to go to the courts to provide expert witness. But the circumstances are that they never get facilitated. They never get, there is no clear structure of facilitating. So they opt to refer filling of police forms to police surgeons who unfortunately do not exist at all our healthcare facilities. So we condemn that habit of asking for money for you to examine. But again, this is also an area where we still need to work together with the judiciary and the rest of other entities to figure out the best option, because the medics, we've really interacted and closely with them, and many of them actually don't want to fill the police forms, and you know that jeopardizes the access to justice. Those who feel, they are like, would rather get this money in advance and keep it so that when they call us to go to court, we use it as transport, because we always get embarrassed and use our own resources. So it's also another complex discussion that we might have to continue to discuss. The issue of disability, the disabled teenage moms and others, I want to confirm to you and mention that this is an area that we are also working on. In fact, we recently revised, I think it was more of developing disability inclusion guidelines to cater for other categories of populations that are, and these days we don't say disability, we say able differently. So it's something that we we are actually rolling out and encouraging facilities. Right from infrastructure, when you look at the new Ministry of Health structure plans, they factor in disability inclusion. Whether you are in a wheelchair, we should be able to freely enter labor suit. And so that's being addressed. It has been an issue, I don't want to deny, but it's something that we are working on. Somebody also asked the Ministry of Health to respond on the issue of strengthening families. And yes, and I know that my colleague from the Ministry of Gender, I know that question was supposed probably to be addressed to him. But I know that the gender is also recently, I think one of the commissioners promised us a gift before the year ends, that they are going to publish the national parenting guidelines to be able to, to guide better in terms of how parents should be able to take on their roles. It is true that we have very many parents whose job is basically to produce, but when it gets to parenting, it has been a big gap. But again, like I mentioned, the Ministry of Health alone may not be able to really do this work alone, but it requires, for example, gender and other actors, the Ministry of Education, and all of you who are seated here to contribute to strengthening. And I think there are very serious family issues in the country, and I think that's why also the children are also getting issues. So we need to strengthen the families so that, the children are also able to live. I think those were and then somebody asked me, probably, what is the recommended age for you to start producing? So there are two answers. One is biological. The biological answer is that you should start producing when your body is able to really take care, is able to support a baby. And usually that happens, that usually happens after 20 years. I'll not say that at 22 and a half years, at 23, but you must be prepared, both physically, because almost all these young girls below the age of 20, we deliver them through cesarean sections. That's an abnormal delivery. So all those are people who should not ideally have conceived. So the most clear answer is below 20 is clearly it's a danger. Then after 20, it depends on other factors. Your nutritional status. You can be above 20, but you are malnourished. The baby is going to starve and also die. So there are a number of factors. Even emotionally, you should be ready to produce when emotionally you are also ready. The person, you are already getting into a family. There's somebody who's going to take care of what? Of that child. So, but if you're getting into a program of conceiving, when there is nobody who is clearly there to provide emotional support, then you are also still not what? Not ready. Let me stop there for now, but I'm told there are more opportunities during lunch hour to interact. Thank you.
Thank you so much for responding to the question. Maybe, yes, quick round of applause for the doctor for this clarification to the girls and other responses. I will keep the question on the accountability to other members as well, as you are calling coordination in these regards, but maybe we can move to Ms. Lucy, representing Ministry of Justice. I think you got already a question from the audience that is very much related. That's the question that we prepared for the panel regarding the backlog at the court in terms of the cases. So we have seen, as per the statistics, an increase in terms of SGBV. How many cases are being investigated and the conviction rates, and what Ministry of Justice is doing to improve those conviction rates, as we get the question from the DCDOs in terms of the backlog and what are the actions that are in place to support and improve that backlog. Thank you. So over to you, Ms. Lucy.
Thank you. Thank you, Laura. I want to start with the question from Buko. And sir, you were asking about cases against children and how they, I think they delay at the police and they're not concluded. Legally, cases against children at investigative level is supposed, a child once arrested should be processed within 24 hours, and that child should be taken to court. Now, for Buko, you have a double challenge in the fact that there's no remand home nearby. The nearest remand home to Buko is in Bale, which I think is over 2 hours or so away. Now, on the issue where some cases may be handled at police, is that the Children's Act in Section 89 gives power to the Inspector General of Police to come up with guidelines pertaining to channeling the children away from the criminal justice system. And these are children who have committed offenses that are not grievous in nature. This is what the concept that we call diversion. Now, what we have increasingly come to understand as a sector is that most of the community doesn't really understand the concept of diversion. And it seems like as Ugandans we've become increasingly litigious, that every case that is reported at police, that person must go to prison. And they don't understand that if this child comes back to the community within 3-4 days, that child is actually under some form of intervention. And that intervention is that child should be handled within the community or the family structures. And that's what diversion is about. That children that are charged with those cases that are not grievous in nature should be handled in a way that does not bring them into the criminal justice system. Should they be cancelled? Should they be handled by the LCs? Should they be handled by the community structures? And that is something that we are doing as a sector because, one, we have very few remand homes. We have only 7 remand homes in the country. We also have a policy shift over the years that children should not be institutionalized. That children are humans that are bound to make mistakes because it's part of the learning process, but that as they make those mistakes, we shouldn't keep them in a space that may make them even get worse. And that's what diversion is about. That being said, we are constructing a remand home in Moroto. Those of you from Karamoja area, you know the challenges that have been happening, but I'm glad to inform you that the funds have been found, and we hopefully should be complete by the end of the financial year in June next year. And the other issue has been, I want to talk about the medical examination fees. Now, one of the issues we've been dealing with under the medical legal task force is on the issue where there's seemingly 2 policies. Whereas the Ministry of Justice, the justice sector provides money as an incentive. Because I think while we were trying to address a problem, we created another problem. In 2012, the Justice Steering Committee sat, and one of the issues that came up was on the low turn-up of witnesses and the poor case outcomes of SGBV cases. And one of the solutions was that, okay, if we give these doctors some payment, it will encourage them to fill the police Form 3s. Now, that was provided, and it was agreed that 25,000 be given. Now, that money is processed through the Uganda Police Directorate of Medical Services. Now, the funds that are provided is usually between 100 and 150 million shillings. And I want to bring, why am I bringing this? Is that the funds have never been sufficient. If you look at the annual police crime report, which I've carried with me now, if you calculate 14,000 cases, that's the average over the years of just defilement. It's not all the SDBV cases. 14,000 times 25,000. I used to leave the math class early, so I'm not sure what that comes. But on average, we need to fund to between 500 million to 800 million annually, just for medical examination. Now, we also get to know, as we engage as the Medical Legal Task Force, that the Ministry of Health has a policy where the medical personnel are supposed to treat everybody, including the victims of SGBV cases. Now, how do you tie in those 2 issues? And we have a situation where quite a number of doctors are hugely indebted. that they haven't been paid for, maybe there's a backlog for 2-3 years and they've not been paid this money which they're legally entitled to. The other issue we have now also come to find out that whereas these doctors, or some of these doctors, get paid at the point of treating these, examining these victims, they are also asking for that money from the police medical, because they're supposed to fill in that form which goes to the Police Directorate of Medical Services. So there's an element of double payment. On a personal level, I'm not speaking as the Minister of Justice, I think that money should be scrapped, and we go with what the Ministry of Health mandates, that the doctors are supposed to medically examine these witnesses. What then should be done, and what we are now doing, is the intervention at the judiciary. And what has been happening is that when you are called, when a doctor is called as a witness at the High Court, there are funds that are provided for witness support, which is transport. It's not payment for their services as experts. It is transport refund, which is for everybody that comes as a witness in a criminal matter in the High Court. I'm speaking slowly, it's intentional. Criminal matter at the High Court. Okay? What we have now also been doing, as when these challenges came up, is that we realized the cases of defilement, there's two defilements. There's defilement, which the police choose to call simple defilement. There's nothing simple about defilement, which is defilement and then aggravated defilement because of the 4 aggravated situations that are mentioned in the law. Now, the defilement cases are handled at the chief magistrate's level. And for a long time, resources were not being provided at chief magistrate's level for transport refund. So some of those doctors would be called at that level and there's no resource. But over time, we have now started, the fund is not sufficient as at the High Court, but they are now receiving money for witness support. So I think I'll leave it at that.
Yeah.
Now, I brought this police, Laura, I think you've asked about statistics. And in 2022, the statistics from the annual crime report is that the cases of defilement went down. They went down by 38%. The sex-related offenses also reduced by 10%. Domestic violence increased by 1%. What is really alarming is the child-related cases, and it's tying into what we are talking about today. The child-related cases increased by 55% in 1 year. Now, I wanted to read to us what the police lumps as child-related offenses. This is the categorization. Child neglect increased by 1,544. We had the first girl who testified. There was an issue of child neglect. Child desertion increased by 398. Child abuse, child trafficking, child abduction, child disappearance or missing children, child stealing, abortion, and infanticide. So all these 9 categories of cases are under child-related offenses, which increased by 55%. From the beginning of the day, we have been told that it is about all of us are invested in this issue. It's not just about the justice system. The justice system is at the tail end. Prevent, prevent, prevent. What are we all doing? Now, in terms of statistics, also, I received information from the Office of the DPP this morning. Also, just to highlight, I know the questions usually come, how come there are so many cases in the police annual crime report and then very few at DPP? I want to mention that the police annual crime report is collated according to the calendar year, from January to December. All the other justice entities report according to the financial year, which ends in June. And so we are working around having a system where we can get the information collated to show one period as opposed to 2 different periods. Now, what I received from the DPP this morning, that last year they received these are criminal cases, sexual SGBV cases, 7,928 cases. Of those cases, they sanctioned 4,149. I want you to see how over almost 3,000 cases have not proceeded to be sanctioned. Now, some of these cases have been sent back for further inquiry. Some of these cases have been found to either be civil in nature, or some of them have been found to not have sufficient evidence to warrant, to have a reasonable ground for conviction. The DPP is the office that sieves which case proceeds to court and which one does not. The Constitution gives them the mandate to direct investigations. Now, of those, 1,450 cases were closed. Under hearing was 12,655 cases. Convictions for that year were 1,301, and the cases that were dismissed were 628, and those that were acquitted were 35. Now, the statistics are not good, because almost half of the cases that are submitted, that are reported to police, don't necessarily get to the office of the DPP. And why? We have been implementing the special sessions. And what we found out is that most of the defilement SGBV cases happen within one, the family setting, the household setting, the community setting. They will report today, and tomorrow those same people will come and say they are no longer interested in proceeding with the matter. And sometimes it's because of intimidation, it's because of fear, it's because they have used their community structures to sort out the matter, and sometimes they say they want to preserve the community relations. And as a justice actor, do you proceed? You cannot, because you need a witness to proceed with the matter in court. So as we are quick to say that the cases are not proceeding to the DPP, it's also important to understand the community dynamics under which SDBV occurs. I think I'll leave it at that.
Thank you so much, Ms. Lucy. I think I allow you to go with all those explanations as you were responding the main question as well, but also because I think all of us, we were learning a lot from the clarifications. I'm happy, and I hope that the ministry is taking note of that key question for the medical, legal, technical working group to take forward in terms of one of the key challenges that needs a solution to mitigate a harmful impact of some of the guidelines. And thank you so much for all the clarifications regarding the reports, where are we, and sometimes lack of reporting doesn't mean that the cases are not there, as you mentioned. It's about the reporting and the enabling environment to continue with the case. So we need to wind up quickly, so I request Ministry of Education and Gender to be focused on the key questions from the audience. Let me start with Ministry of Education regarding other interventions beyond the re-entry guidelines, especially for teen mothers with disability. If you can respond quickly, Ms. Rosette, 30 seconds, thank you.
Thank you very much. Children with a disability, what are we doing to support their re-entry? Like I've already shared, that once we developed these guidelines, we've been able to strengthen the capacity of our teachers so that there is a safe return for the child mothers, including the children with the disabilities. But also when it comes to messaging, the messages that go out, how do we ensure that they are in accessible versions? We have embarked on translating all our message booklets into versions that can be accessed by the children with disability. We have audio, visual materials that are being developed. We are brailing, but when it comes to children with disabilities, the categories differ. You may find that you're brailing information, and yet we have the blind, we have other categories that are not even in any of those two. So sometimes it becomes difficult, and because of that, we're also building our capacity of our teachers to ensure that they can be able to speak to our children. We have special needs teachers. So we are building their capacity to be able to appreciate these issues, and then they will be able to translate this to the learners. Thank you.
Thank you so much, Ms. Rosette, for the response. I say confirmation in terms of responding to the question that was asked by the girl. We appreciate that. And finally, I think for Ministry of Gender, two related questions in terms of mentorship for DCDOs, especially at mindset change at cabinet level. That was one of the questions, and from the girls as well, strengthening the family institution to support adolescent health and that enabling environment. What the ministry can do in this regard. Thank you.
Yes, thank you. The ministry is doing two critical things. First of all, we are piloting the Child Sensitive Social Protection Program for our colleagues who are here from the West Nile. You know that one, we're already targeting mothers, teenage mothers, and young mothers who have children below 2 years. And our focus is on improving nutritional outcomes for those children. So most likely we find that the mother who is 14, who is 15 cannot breastfeed. There's going to be a very, very big challenge. So providing nutritional support to those mothers through what we call NutriCash is very important. That is the first. The other is looking at ways in which we can actually improve child care generally. You know, we've just done a study, a landscape analysis for the legal and institutional framework for child care. So when we talk about child care, all the issues that we talk about for our teenage mothers is going to be really focused on that. So we have a high-level dialogue next year. We are going to bring on board stakeholders to really be able to discuss it. But again, for the children, for our teenage mothers, we already have an intervention package which was focusing on adult parents called the Boost for the Youngest. And the Boost for the Youngest was looking at promoting early stimulation for the very youngest children who are below 3 years. Now, we really want to reform that package to be able to cater for our teenage mothers. How do they support the well-being, the growth and development of this young baby that they have? Because, you know, if they don't support this baby, they are not going to settle. However, if they fall short, we are going to have an endless cycle of having teen mothers. So we want to really revise that to see how we can revise that package, the toolkit, to be able to cater for the youngest mothers. Lastly, on income support. Under income support, we have interventions for improving our livelihood incomes. And under there, I think last year, we started the disability grant, what we call the special grant, targeting mothers who have disabilities, but also targeting mothers who have children with disabilities. And that we believe can be able to buffer them from the economic situations or hardships that they are facing. On top of our other programs that are livelihood programs. What I'd like to mention is that we also want to look at more the linkages between livelihood and overall social and economic outcomes for family members. If someone is benefiting from PDM, are their children going to school? Are their children getting all immunizations as planned? Are they having a birth certificate? So tracking those outcomes is going to be really central for us. Because if someone is benefiting from a livelihood program by government of Uganda, we should expect that all your children complete school, all your children are healthy, all your children are well nourished, and all your children are safe. That is the linkage that we want to bring. And that is now the work that we want to support our CDOs who are doing the assessments and evaluations, to see that the people who are in most need of that support, the vulnerable families, not the well-placed families, not the families of politicians or councillors or what. We want to see that those families that are highly vulnerable are the ones benefiting most from the livelihood support. Because to them, that is what is going to make a big difference from the children or the girls in those households.
Thank you, Mr. Rogers. I think for the takeaways of the symposium, I hope that we took note about these tracking outcomes from the different interventions of the government. So how the government is going to do that is maybe non-responded question, but we are running out of time. I hope that we can continue that discussion, including the one in terms of mindset change at cabinet level. That was asked, that we are looking for a response. So we are hoping that we will continue those discussions at the high level policy dialogue that Mr. Rogers was talking about. So let me just finish the panel with an opportunity for the panelists with one sentence each one of you. about from what was discussed today, what is the commitment in representation of the institutions that you're representing here today? What you are going to do differently to accelerate the efforts to support teen mothers and their babies? Let me start with Ms. Lucy, one sentence.
It's not really differently, but it's about strengthening the response systems. As I said, for us, it's about its response. And response includes ensuring that the human resource is present. Currently, we are in 74% of the districts in Uganda. We are ensuring, our commitment is to ensure that we are functionally and physically present in the whole country. It's ensuring that we recruit. We have 649 judges, less than 400 state attorneys. For 45 million Ugandans, we want to ensure that we have the physical resource in place. The other very critical thing we want to do is scientific management of crime, forensics, because SDBV happens in a situation where there are no witnesses. So once we have the science, we think that we can have better case outcomes.
Thank you so much for those two commitments, and also remember to take forward the one on the medical, legal, technical working group, as we need a solution for that one. Let me move to Ms. Rosette from Ministry of Education. One sentence, what is the commitment from Ministry of Education considering the gaps?
Thank you very much. Thank you very much. I think for me, looking at the lessons we are learning, we've not engaged well with the political leadership, and I think time has come for us to really engage more, not just the politicians at the local, national level, but also at the district level, to be able to speak to the issue of re-entry. The other thing is bringing men and boys into this discussion. Men interface with these realities on teenage pregnancy and child marriage, either as perpetrators, negotiators, or allies. So I think positively we need to engage them so that we can have positive results to ending this child marriage and teenage pregnancy. Thank you.
Thank you so much, Ms. Rosette. We will be looking forward next year to see the progress on implementation at the district level of the re-entry as per the commitment of the panel. So let me move to Ministry of Health. 30 seconds, one sentence of commitment. Thank you.
Yes, so thank you so much. One, let the evidence guide the interventions. Let the data speak. And allow me just mention that in our last year's report on why mothers and babies die, among the less than 24 years of age, the leading cause of death was abortions. And looking at the under 19, they contributed 29% of all the maternal mortality under 19 were abortions, as much as we are talking about teenage pregnancy. Between 20 to 24, largely, usually those are university students. 22% of all those deaths were abortions. So why I'm saying that let the data guide the interventions is that sometimes our interventions are political and people don't want to accept the what? The truth. So when you add those two figures, 48%, close to 48% of all maternal deaths in the country were abortion related. What does that mean? Women and girls are aborting. But sometimes if I were somewhere and I start speaking about abortions and somebody will be like, hey, stop talking about what? So that's why I'm saying that let the data speak. Let's really speak the truth. I think most of the times people don't speak the truth. I think my sentence is let us speak the truth.
Thank you so much, and we celebrate the commitment from Ministry of Health to use the data that you have to continue advocating and use the data at the high level, at political level, to drive those mindset change. So we appreciate and celebrate that commitment from Ministry of Health. And finally, let me go to Ministry of Gender as the key ministry leading on the National Strategy for Teenage Pregnancy and Child Marriages. In one sentence from the discussion today, what is the commitment in terms of coordination for the implementation of this strategy? Thank you.
Yes, our commitment is to galvanize all stakeholders to invest in implementation of the national strategy to end child marriage and teenage pregnancy. So far, the number of partners that we have supporting us in implementing the strategy are still very few. So we need to galvanize more stakeholder support towards implementation. We need to guide stakeholders to decentralize funding to local governments, especially the Department for Community-Based Services, to invest in the work that our probation officers are doing, but also most importantly, to also sustain social behavioral change communication, that is the awareness raising and creation at all levels to ensure that the issues of child marriage and teenage pregnancies are prevented, but also easily responded to by all stakeholders.
Thank you so much. So big round of applause for all of our panelists, but also to you, the audience, for those key and critical questions. I think you asked the questions that have been enabled the panelists to find solutions to existing problems. So we appreciate your active participation and listening as well. So a big round of applause to you all. Thank you so much, and over to you, Frank.
Wow, what a brilliant job. Let's give them another round of applause. Thank you, Laura, for steering this very, very ably. Done a brilliant job. Thank you so much. And your team, I think we wouldn't have a better team than this, isn't it? Very informative, they know what they're talking about, sharing new critical information. We've learned a lot from all your submissions. I'd like to thank you so much for that. And ladies and gentlemen, I guess by now you already have a coupon with you. That is your pass for lunch. And therefore, I want to invite you for lunch. We'll return back after 40 minutes for the other sessions. Thank you so much.